Can an outpatient practice be on the cutting edge of interventional radiology, or is this reserved for academic centers only?
Now, looking at a lot of trials, I can name a number of investigators of influential trials who are based out of outpatient labs. So I don't think it's a hindrance. In some ways, private practice docs can change direction, pivot on a dime, and move faster due to the lack of bureaucracy typically found in larger systems. There are procedures that I do in my freestanding facility which aren't done within a 500-mile radius, including academic medical centers that we compete with. An example of this is geniculate artery embolization for knee pain or embolization for frozen shoulder. However, outpatient practice can be a hindrance to progress from a reimbursement standpoint. Hospital systems and academic facilities have larger budgets to absorb costs that are not reimbursed in outpatient facilities. Off the top of my head, I can think of two things that fall into this category. Drug-eluting balloons. Drug-eluting balloons are not specifically paid for in site of service 11, which is outpatient practice, but can be absorbed within the other costs that a large health system can take on. Another one is investment in endovascular robotics. That involves a huge capital outlay, which a large organization can do, and is really out of the goal of a small outpatient lab. The doctors that I know who are using these newer technologies tend to be in larger institutions. And unless you're willing to invest in a research coordinator, and we haven't, it's sometimes difficult to coordinate study trials.
So Dr. Gorin, tell me, what do you think about docs who are in the private practice space as opposed to docs who are in the academic space? Do you feel at all disadvantaged that you may not have access to the same technologies or any sort of research or any sort of institutional capabilities? Do you feel that you're not on the cutting edge for any particular reason as a private practice doc?
I guess I might argue the reverse in that, first of all, if you're talking about just office-based care, which I think as far as a way that we're going to be delivering vascular care in the future, the employed academic docs have been walled off from this, and they have been prohibited from being able to do this. And there's a lot of care that we've seen that has developed out of the private practice world and has moved in. I mean, the classic one that people talk about is laparoscopic surgery and laparoscopic gallbladder surgery, which came completely out of the private sector, and it took quite a while to get into the academic centers. So, I feel like we're really on the cutting edge and are continuing to move the bar from a technical standpoint and getting less and less minimally invasive on how we care for this patient population. In my own practice, our group is just finalizing purchasing a clinical practice. A clinical research company so that we're actually going to be doing clinical trials with industry. So we're going to have very early access to devices, and the companies are really pretty excited about having office-based centers as places that they can do this because there are a lot of challenges in working in large academic centers in terms of bias problems and issues with dealing with IRBs and so on. And we're a fairly straightforward way to work that can be simple for them. We can recruit a lot of patients. So I feel like our patients are going to get very early access to technology that will rival and I think surpass a lot of academic centers pretty easily.
So Dr. Tara, tell me, you have one foot, a small foot probably in the academic side, since you said you have a presence there, but you also have your outpatient practice. Do you feel at all disadvantaged as a private practice doc being on top of the latest and greatest? Because a lot of fellows may feel that the real big things that are being done are maybe being done in big academic institutions. What's your take on that? Do you feel at all disadvantaged?
No, I actually just the opposite. I mean, again, I've presented some things and written some things, and I've developed some techniques that I don't think I would have had the opportunity to do had I been in full-time academics, because let's face it, there's more inertia. To some degree, there's more scrutiny. And to some degree, somebody like me that thinks a little bit outside the box and is kind of creative and innovative on some of these things would get actually impaired by some of the inertia and things, processes that are in academics. So I don't believe that I've really been disadvantaged from that perspective. I mean, we've done clinical trials. I've co-authored numerous papers. I developed my own techniques. In terms of access to latest, greatest technology, now, again, this may not be for everybody, but I actually do a fair amount of device development work. And so over the years, we've been a little bit of a skunk works. And when somebody comes up with something new and they really want some honest feedback, whether good, bad, or indifferent, a lot of times they'll bring it out to Bradford and we'll put it into action and take a look at it. And then we'll give them very honest feedback. Not everybody wants honest feedback, to be honest with you, but that's what we give from here. I think the biggest disadvantage to what you're alluding to isn't access to technology. My biggest disadvantage is I have no less than 8 manuscripts backed up that have been backed up for 2 or 3 years. I don't have time to write. So I've got data that I would like to get published about, sometimes large case volume experiences, specifically a lot of my ultrasound guided tibial stuff, some new techniques for using lasers, things that we've done. And we have now a pretty robust clinical experience on and good data. But the time for me as a busy private practice guy, plus being involved in all the other things I'm involved in, OEIS leadership, running the registry, being an at-large MedCAC member, doing the advocacy work I do, there's only 24 hours in a day. And so what suffers is my ability to publish. Now, that's not important for everybody, but that's what I would say the greatest disadvantage has been.
As an independent private practice doc, how do you stay on top of the latest and greatest things that are going on in the field? Do you think that you can compete with academic centers where they may have more access to that, or what do you feel about that entire concept?
I think you can absolutely compete with academics. In fact, I think academics are slow to respond and are not at the cutting edge oftentimes. I think that when you're in private practice, you have the ability to make your own decisions. I think it's imperative as a physician, whether you are in academics or private practice, to stay engaged with your community, stay engaged with your societies, go to national meetings, participate in those groups, and talk to people, talk to your peers. But I think it's absolutely not an issue to do that in private practice. In fact, I think that you can be more connected in private practice than you can in academia.